Next, we have sets of ligaments that support the sacroiliac joint. You have two that directly stabilize the sacroiliac joint, and those are the anterior sacroiliac ligaments that run from the anterior sacrum to the anterior part of the ilium or the innominate. Then we have the posterior sacroiliac ligaments. They are the short dorsal ligaments as well as the long dorsal ligaments. So we have the anterior or ventral sacroiliac ligaments. We have the posterior or dorsal sacroiliac ligaments. The anterior and posterior or ventral and dorsal sacroiliac ligaments provide direct stabilization to the sacroiliac joint. Again, the anterior and posterior sacroiliac ligaments provide direct support to the sacroiliac joints. There are two other associated ligaments that support the sacroiliac joint indirectly. There is the sacrospinous ligament that runs deep. There is the ischial spine. So the sacrospinous ligament runs from the sacrum to the ischial spine. The other is the sacrotuberous ligament that runs from the sacrum to the ischial tuberosity. This is the part of the pelvis that you are sitting on, maybe right now listening to this presentation. So the indirect stabilizers of the sacroiliac joint are the sacrotuberous ligament and the sacrospinous ligament. One more ligament associated with this area is the iliolumbar ligament. The iliolumbar ligament attaches from the ilium of the innominate to either L5, generally in females, or L4 and L5 transverse processes in males. The iliolumbar ligament has little to nothing to do with the sacroiliac joint and provides no support or no substantial support to the sacroiliac joint. So you have two ligaments that provide direct support and two ligaments that provide indirect support. The iliolumbar ligament more so supports L5 and sometimes L4, much more so than it has anything to do with the sacroiliac joint. Next, let's discuss the vertebral blood supply. As you can see, it starts with the segmental arteries. Each area of the spine gives off these quote-unquote segmental arteries. In the lumbar spine, they are simply called or referred to as lumbar arteries. These arteries emanate from the abdominal aorta. In the thorax, the intercostal arteries emanate from the thoracic aorta. And in the cervical spine, the deep cervical arteries come from the costocervical trunk. So the lumbar arteries, intercostal arteries, and the deep cervical arteries are the segmental arteries that provide blood to the spine. The segmental artery will give off a ventral ramus artery and a dorsal ramus artery. Ventral ramus arteries will go to the areas within the trunk, and the dorsal ramus arteries will go to the muscles and structures along the spine. The dorsal ramus artery will give off a spinal artery. The spinal artery will in turn give off a anterior radicular and posterior radicular artery. Radicular means root. The anterior radicular artery will run with the ventral root. the posterior radicular artery will run with the port dorsal route. The anterior radicular artery will provide blood to the vertebral body. The posterior radicular artery will supply blood to the pedicle, lamina, transverse process, and spinous process on one side. The anterior radicular artery will connect into or terminate at the anterior spinal artery on both sides. The posterior radicular artery on the right and the posterior radicular artery on the left will terminate in posterior spinal arteries, one on the left and one on the right. The anterior and posterior spinal arteries travel vertically within the foramen magnum. This anterior and posterior spinal artery will provide a redundancy in blood supply in case there is a blockage of one level. Blood will be available at another level. While this may not prevent some level of tissue ischemia, it's a bit of a reassurance or a method of assuring that or limiting the chances of ischemia and bone death. I'm not going to spend a lot of time on the venous drainage of the bones and of the spine but I will say that it is extensive, probably twice as extensive as the arterial blood supply to the spine. You have a series of segmental outputs, similarly to the segmental arterial inputs. These segmental outputs drain into both an anterior and posterior longitudinal sinuses. These sinuses travel vertically within the foramen magnum. Any segmental blockage, as in this picture, a blockage of the lumbar vein would cause an engorgement of the anterior longitudinal sinus, which could compress the spinal cord. So there are 4 structures that we have mentioned that could block or compress the spinal cord. They are the posterior longitudinal ligament, ligamentum flavum, the dens, in the case of ligamentous rupture or ligamentous fracture of the dens, the anterior longitudinal sinus. So those 4, PLL, ligamentum flavum, the dens, and the anterior longitudinal sinus, can all cause compression on the spinal cord. Remember this diagram from the last presentation? Well, next I want to discuss the innervation along the spine of both the facets and discs. This innervation comes from 2 nerves. One nerve, called the sinovertebral nerve, comes out at the base of the spinal nerve, where the dorsal and ventral roots connect. The other is a nerve coming from the dorsal ramus, that is a sensory portion going to the facets. Here is a fairly detailed drawing or diagram of the spinal nerve exiting the intervertebral foramen. So here is the intervertebral foramen. This is the spinal nerve, the same spinal nerve pictured on the prior diagram. The spinal nerve will branch out a ventral ramus and a dorsal ramus. That ventral ramus is the nerve traveling to the trunk and extremities. The dorsal ramus will have a lateral branch, which is the muscular branch to the muscles of the back, which we'll be discussing next week, as well as a medial branch. That medial branch has a descending fiber that has a local fiber and an ascending fiber or branch. So each dorsal ramus has a branch that descends to the facet joint below. It innervates the facet joint at the level, and it innervates the facet joint above the level. This means that every facet joint is innervated by 3 separate spinal nerves. For example, this facet joint above is innervated by the ascending nerve from the joint below. It's innervated by the local dorsal ramus at the level, and it's going to be innervated by the descending branch from the dorsal ramus above. This makes diagnosis of facet joint pain difficult because of the number of possible culprits. The other nerve we spoke of coming from the base of the spinal nerve actually comes from inside the intervertebral foramen or medial to the intervertebral foramen is the sinuvertebral nerve. That sinuvertebral nerve travels out and innervates the disc at as well as the disc above. This means that a lesion of the spinal nerve will affect the disc at and the disc above the level of the lesion. It will also affect the facet joint at, the facet joint below, and the facet joint above via the dorsal ramus. This is a schematic drawing showing the spinal nerve with the sinuvertebral nerve coming off first. This is the local disc innervation and the disc innervation above. The spinal nerve will travel through the intervertebral foramen. Here is the ventral ramus with its sensory and motor components. Here is the dorsal ramus with its muscular or motor component, along with the descending branch, local branch, and ascending branch to the facet joint above, the facet joint at, and the facet joint below. Here is just a comparison of those two pictures in order for you to help you wrap your head around or assimilate one to the other. Hopefully, one of them will make sense to you. It's not enough just to understand or know the architecture of the spinal nerve, sinuvertebral nerve, and dorsal ramus. You will be asked to be more specific in which discs and which facets are involved in the injury to either a spinal nerve or dorsal ramus. In the cervical spine, the cervical spinal nerves exit between or through the intervertebral foramen above the vertebral level of the same number. For example, the C4 spinal nerve exits through the foramen superior to the 4th cervical vertebrae. C5 exits through the intervertebral foramen above the 5th cervical vertebrae. C6 exits through the intervertebral foramen superior to the 6th cervical vertebrae. C7 exits through the intervertebral foramen between or superior to the 7th cervical vertebrae, and there is an 8th cervical spinal nerve which exits superior to the 1st thoracic vertebral body. What C8 causes is a shift in the naming and numbering of spinal nerves as they relate to the vertebral bodies of the same number, such that in the thoracic spine, the 10th thoracic spinal nerve exits through the foramen that is inferior to the 10th thoracic vertebrae. The 11th thoracic spinal nerve will exit through the foramen inferior to the 11th thoracic vertebrae, and so on and so forth. If you can master and understanding the numbering system of both the nerves and the vertebral bodies, naming the structures involved with a spinal nerve or dorsal ramus injury should be relatively simple if you know what is involved with which type of injury. For example, with a C8 spinal nerve injury, with any spinal nerve injury, the disc at and the disc above is going to be affected. So with a C8 spinal nerve injury, the local disc would be affected, so that would be the C7T1 disc, and the disc above would be affected, the C6-7 disc. Also associated with a lesion of the C8 spinal nerve would be the facet at this level, the facet above, and the facet below. So the local facet would be C7T1, the facet above would be C6-7, the facet below would be T1-2. In the thoracic and lumbar spine, since the numbering is a little bit different, the outcome from any spinal nerve problem will be a little bit different, or it will affect different discs and facets based upon the change in numbering. For example, the T11 spinal nerve injury will create issues with the T11-12 disc as well as the T10-11 disc. The T11 spinal nerve injury will also involve the T11-12 facet, the T10-11 facet is the facet above, and the T12-L1 facet is the facet below. If you are given a dorsal ramus lesion, the dorsal ramus is inferior and lateral to that of the sinuvertebral nerve. So with any dorsal ramus lesion, you will not have any disc involvement. The only involvement that you will have is the facets. So going back to C8, if this were a C8 dorsal ramus lesion, you would involve the C7T1 facet, the C6-7 facet, and the T1-2 facet. You would not have any disc involvement. Conversely, if you have an L1 dorsal ramus lesion, the L1-2 facet joint would be involved, the T12-L1 facet would be involved, and the L2-3 facet would be involved. Each example, I would suggest drawing out these figures. When I draw them, I start by just drawing boxes and lines as indicated here without any numbers. I will start by numbering my cervical nerves. If I'm in the cervical spine or I have a cervical example, I will start with one of the cervical nerves in the area, and I will just write 5, 6, 7, 8, T1. Got to remember that 8th cervical nerve. In the boxes, I will know that in the cervical spine, the 4th cervical nerve comes out above the 4th cervical vertebrae. So I will just write in those boxes 4, 5, 6, 7. I know there's only 7 cervical vertebrae, so in the next box I will write T1. This will assure that I will have the correct orientation between my numbering on the cervical spinal nerves and the cervical vertebrae. I will do the same thing in the lumbar spine. I will number one of the adjacent spinal nerves to the spinal nerve in question, and then I will number above and below, just going in numerical order. With the boxes, I will pick one of the thoracic or lumbar nerves, which has already been numbered, and I will know that the vertebrae above the numbered nerve shares that number. So the T12 vertebrae will occur just above the T12 spinal nerve. So I'll write 12 in there, and then I'll go up to 11 and 10, and I know there's only 12 thoracic vertebrae, so I will start numbering 1 and 2. Separating them out and knowing the orientation of the cervical nerve to the vertebral body in the thoracic and lumbar spine will almost assure that you will not make any careless mistakes as you name the discs and or facets involved in the lesion.